And here we go. So this is part 3. So we're going to do thyroid and cortisol, and and we'll see how far we get with that. So this is actually pretty much my afternoon, my second lecture on Thursday afternoon coming up at AMMG. They gave me an hour to do thyroid and cortisol, so I got to burn rubber with them. All right, so the thyroid show. Okay, so thyroid, you can make, in fact, we're putting together at our new anti-aging clinic, we're putting together a thyroid a subscription program, the thyroid clinic.
Yes.
And you can make a whole living out. If you understand thyroid disease, you can make a whole living out of this. Okay, you don't, and that's all you need to do, right? Nobody understands it. The endocrine. So when I give these talks, I don't know if you might have heard this before. So if I was at a conventional medical doctor convention, and I'm going to talk about thyroid disease, here's your lecture. If the TSH is greater than 10, give them Synthroid. If it's 4.5 to 10, give them Synthroid if they have symptoms. And if it's under 4.5, they're psychiatric. Send them to the psychiatrist. Lecture's over. That's it. That's it. You're done. Right? It's a little bit more complicated than that. But endocrinologists, what are you crazy? You people don't know anything, right? Mm-hmm. So and their answer is, well, what about diet? Doesn't matter. What about the immune system? Doesn't matter. So they'll measure, if they don't get anywhere, they'll measure the antibodies, and they'll say, well, there's nothing you can do about it. So none of that's true. Okay. So this part of it is everything we learned about the thyroid in medical school was also wrong. All right. So I like to start really with a little bit of like patient education. So how do you talk to somebody sitting in front of you? I've had thyroid disease for 30 years. And I always ask them, what does the thyroid do? And you got 4 words. You'd say it in 4 words, and the first 2 are, it's your. So, Dr. Rowland, what does the thyroid do? It's your what?
Well, I would say it's mostly involved in metabolism.
Yeah, okay. But remember, we're talking to John Smith, the truck driver.
It gives you energy.
Okay, that's not too bad. I like it this way. What did I do here? Did I skip it? Yeah, I skipped it. Okay. It's your gas pedal.
Okay.
Okay. And I did have a slide with a picture of a gas pedal there. I must have taken it out. So it's your gas pedal. It tells your body how fast and how slow to go. It affects every cell of the body. And when you don't have enough thyroid molecules, you basically slow down. And so everything that works in our system becomes sluggish and stuck. That's basically it. If you hear sound behind me, that's our cat that allegedly 4 years ago had been spayed. It's her time of month. So I apologize for there's not much I can do. We have to give her catnip and play Italian opera. That's the only thing that calms her down.
Otherwise, you get shrieking late at
night. That's where you hear it now. So there's the thyroid has 4 molecules. It makes 2 major hormones, T3 and T4, and 2 minor ones, T1 and T2, which we really don't know what the hell to do with, so we just kind of ignore it. The T3 and T4 are the major regulators of growth and the rate of function of the body systems. Here's a sort of a schematic of it. The T, and this is always, you can tell this to the patients, doctors should know this. The T actually stands for tyrosine. That's the protein, that's the backbone. And pretty much when you look at thyroid supplements, any of them, at least, the good quality ones, they'll always have tyrosine in it. The number 1, 2, 3, and 4 are the number of iodines attached to the tyrosine. And T3, that's this one here, this is the part that does the work. Okay, this is the amount of thyroid that's getting to the tissues. The T4, which is your Synthroid or levothyroxine, is your store unit. So basically, and remember that the endocrinologists tell us the only treatment is Synthroid, T4. Basically, what they're telling us to do is fill up the closet. And when it bursts, then we'll have enough stuff, enough fuel for the engine to run. That's basically what they're telling us to do, which seems kind of ridiculous, right? And then the excuses are T3 is unstable, it causes palpitations, and fill in the blank. And, you know, for the most part, occasionally you'll get someone with palpitations will cut back on it. And again, most of the time it's, you know, your endocrine people, at least the ones in Reno here, you should hear what the patients when they come back and tell me what they say about me. These people. so T3 consists of free T3, the part that does the work, and this other T3 here. This is reverse T3. And we're going to show you a unique way to sort of interpret this. And so you need to know both. So a total T3 basically doesn't tell me anything, especially if it's normal, you know, in the normal range of T3. You don't know if it's the part that's usable, the part that's getting to the tissues, or the reverse or inert T3, which is inert and it doesn't work. It just shows up as T3. So we order as part of our panel free T3 and reverse T3. We do.
So total T3 is both T3 and RT3.
Correct. Yes.
I see.
Yeah.
I thought it was those that were attached to a binding protein. I see.
Yeah, you got that too. You get that too. And then the total T4, again, I don't pay too much attention to even the free T4. I know, you know, they'll do a TSH with a reflex to T4. Okay. T4, remember, that's the store unit. That's not the usable part.
Gotcha.
So it's better if you have more in the store unit than less, but it doesn't tell you, you know, where it's getting to. So in my mind, the free T3 is really the most important of the, you know, of all of the basic symptoms of thyroidism. You need to be Goldilocks, not too much, not too little. With hypothyroidism, that's what we concentrate on, because 98% of the time, that's what you're going to see. Patients come in hypothyroid. Rarely do they come in hyperthyroid. Usually by the time they get to us, I was hot, I was sweating, I went to the hospital, my heart was racing fast, I lost a lot of weight, and then all of a sudden, you know, over 2 weeks, it stopped, and now I gained 40 pounds. So basically, they've had like a thyroid storm that burned itself out, and a lot of times it's not even you know, it's never even recognized. And a lot of times they had it, they had it at home, and by the time they get to us, they have they're hypothyroid. So that's what we concentrate on. So symptoms for hypothyroidism: dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long. Those are the main symptoms. And then, like I said, when I did the homeopathic thing last week, I put those symptoms into my Materia Medica, think-a-later, and I came up with remedies. So that's how I did it. Hyperthyroidism is basically, everything's going too fast. So hypothyroidism, everything's slowed down. Hyperthyroidism, everything's going too fast. So the hair comes out, the eyes bulge out, sweating, soft fingernails, palpitations, muscle weakness, diarrhea, weight loss, warmness. Okay, remember, hypothyroidism, the patients are cold, and in hyperthyroidism, the patients are hot. If their immune system is off and their thyroid is running low, we call that Hashimoto's thyroiditis. It's got a exotic name to us because it was discovered by a Dr. Hashimoto in Japan in 1912. And if you go to Japan, Hashimoto is Smith and Jones in the U.S., so it's not that exotic there, right? And then hyperthyroidism is called Graves' disease. It was discovered by a Dr. Graves. It was a lot later, 1931. It was defined. So, okay, so. I got Hashimoto's thyroiditis. Patients come in, they're all shook up. And so I explained to them, it's your thyroid's running low and it's from your immune system. So what happens when the thyroid goes on the fritz? Again, we already talked about that. The endocrinologists tell us there's a failure of T4 to T3. And lately, the last couple of years, I've been hearing, well, maybe you don't have enough selenium, maybe not enough nutrients. That's kind of a grudging thing. Okay. On our model, we have the immune issue. That's usually number one. Gluten sensitivity, toxin exposure, infectious diseases. the HPA axis insufficiency, iodine deficiency, and certain medications. Okay, and we look at all of those. All right, I usually go in order. I don't order everything all at once, but I'll go down the list until we find an etiology. I think, like I said, we're setting up a thyroid sort of recovery clinic, and I think it's going to be a subscription model. So they'll pay so much for, and they have to sign up for a year. And with that, I think we're going to do all of these at once. We're still figuring out the costs, what it costs us, and we'll do them all. We'll do it, get it all out of the way, and then we don't have to guess. Here are the labs that you need for the thyroid. And you need to do them all, okay? A TSH with a reflex to T4 doesn't tell us a whole lot. All right, the TSH is really not a great test, although again, the endocrine people, that's the be all and the end all. And I don't know if I took it out in this one, but in some other lectures when I just do the thyroid, I have quotes, if you do anything other than TSH, you're a quack, basically. So it's okay. So you need a free T3, free T4, and that one, like I said, I just do that to be complete. The reverse T3, 25 hydroxy vitamin D3, TPO, antithyroglobulin. There should be a TSI in there. So if they're hyperthyroidism, the TSI, that's your immune function. I don't have it on there.
The bottom line, I cannot read.
B12, folic acid, and ferritin.
Okay.
Okay.
TSI, what is that?
Thyroid stimulus. Thyroid. I forget what the S is. Immune. That's for hyperthyroid. That's for your Graves' disease.
Okay.
Okay. All right, so a little bit about reverse T3. I'll just put this in right here. Remember, this is an inactive form. The T4 goes to an inactive T3. It's that upside down T3. Okay.
Yep.
It's not available for function, but if you just measure a total T3, that's going to be part of it. It's an inhibitor of conversion from T4 to T3.
I see.
Your lab values, the normal is 9 to almost 25. But our optimal is less than 15. Okay.
Okay.
And then this free T3 to reverse T3. I've changed this a little bit. It's just a matter of numbers. So instead of 20, so when you take the free T3 and divide it by the reverse T3, and you'll get a number, and it'll be you want it to be greater. I have to change this. It'd be greater than 2.0, not 20. Okay. So we take the free T3, multiply it by 10, and then divide it by the reverse T3. That just gives me a number that a little bit better number to work with. Greater than 2.0 is considered normal. So what we're looking at is the ratio of the thyroid to the reverse T3. And on the next slide, you're going to find that we can use reverse T3 as a pretty good proxy for cortisol dysfunction.
Now, free T3 divided by RT3.
Yeah, so you're going to take.
It would seem to me that the higher the number would be better.
It is. Yeah.
Oh, so abnormal is less than 20?
Less, yeah. So it's actually, so what I do is I take the free T3, multiply it by 10, and abnormal, it becomes 2.0. It just gives you a different look. You can leave it the way it is. But that's what I do. So, okay. So if the free T3 is 3 and the reverse T3 is 10, so I do 3 times 10 is 30 divided by 10 is 3. Okay.
Okay.
If the free T3 is 3, let's say, and the reverse T3 is 20, so it's 30 divided by 20, and that's 1.5.
Mm-hmm.
Okay, got that?
Now, again, the lower the number.
Yeah, under 2.0 is a cortisol dysfunction.
Okay.
Whether it's high or low, you don't really know. You can usually pick it out from the symptoms. So I use the reverse T3 instead of doing the saliva test that they do for cortisol, the 4-point cortisol saliva test.
Okay.
You know that one? If not
For cortisol, yes, I do.
Yeah. Okay. So I used to do that on everybody. That was part of our intake, but it's, it's $250. Nobody reimburses for it. This is about $10, and it's 90% correlates with that cortisol test. So I use this as a screen. It works really well. And so again, 90% of the time it's a cortisol abnormality when the reverse T3 is greater than 15.
Ah,
The other ones are here: diabetes, calorie restriction. So your intermittent fasting people, beta blocker use, and some iron deficiency also. Okay, but mostly I use it as a cortisol. I use it as a screen for cortisol.
mhm.
It's actually because cortisol. When you get the lab test for cortisol, a lot of times if they didn't get it right, they shook the cells up. They didn't get it at the right time. There's a lot of variables. So this works reasonably well as a proxy for cortisol. We look at TPO and antithyroglobulin. You need to do both of them because sometimes one will be positive and one will be negative, and either one of them is positive is a positive. This is the LabCorp value. There's another so Quest and the big hospital here, that this number will be less than 9. It's just the calibration. Okay.
Okay,
So
gotcha.
this is the LabCorp value. Antithyroglobulin, again, less than 4 is the Quest one, less than 1.0 is the LabCorp one. Okay. All the little hospitals around here, some people that, they live out in the middle of nowhere and they go to these little tiny hospitals. Most of them use the Quest scale, so they all come in with the same numbers. But what you gotta do is you gotta look at the reference range, because if they come in with a TPO of 18 and they're on the at the Quest scale, that's abnormal. If they come at 18 and with LabCorp, that's normal. So you have to take a look at it. I figured it out. It's about 3.75. The Quest scale, you need to multiply by 3.75 to get you to the same number for
Now,
LabCorp.
are these two usually associated with hypothyroidism?
Yeah, yeah. These are the hypothyroid ones. Okay,
Okay,
and here's that TSI. Okay, that's for hypo.
I see.
Okay.
So
Okay.
it's associated with hyper.
Yeah.
That's the one that acts like thyroid stimulant. So it acts like the original TSH. You right?
Right. Yeah.
Okay.
Yeah.
Got it.
Okay. Now, just as an aside, there's some thyroid influencers, on YouTube, and right, they sell thyroid, right? They'll tell you that any TPO greater than 1 they consider that an autoimmune issue. Okay, so you'll see they'll tell you that, oh, they have Hashimoto's thyroiditis. Their TPO on the LabCorp scale was 10. They consider that positive. Okay.
Who is that now?
There's a guy named Weston Childs. There's
Okay.
another one, Isabella Wentz. There's a website that's actually pretty good. They got a lot of stuff that we do called Stop the Thyroid Madness. I don't know if you've ever seen that.
No.
Yeah, they wrote a couple of books. It was basically a couple of lay people that said, their TSHs were normal and they were sick as hell all the time, and it turned out they had autoimmune issues that nobody looked at for 10 years. And we have those patients. In fact, I have on YouTube, I have an interview with one of my patients that I did it for the AMMG last time. I did a little short, like a 3-minute interview with her. And this lady, she came to me. I had, when I first moved to Reno, I met a guy, he's my bookkeeper. He, at the time, was trolling married women's hookup hookup sites. And
Okay.
he was always on, oh, look at this one. Oh, look at this one. So he calls me one day. He says, I got this lady. Can you do some Botox on her? So he brings her in, and first of all, he's 5'6" and weighs about 200 pounds, and she was 6'2"
Wow.
to begin with. All right. And it's like, he says, so I think I probably alluded to, I'm a ballroom dancer. So we go out a lot, we go, music places a lot. He goes, why don't you want to go out with us? I said, we're in Nevada. Everybody has a gun, right? When her husband finds you and he starts shooting, he's not going to say, oh, the guy standing next to you had nothing to do with it. I said, no, thanks. right? So she comes in, we do her thing. She's, she's kind of a whack job, but what'd you expect, right?
Yeah.
And I don't know, they went for a while. Anyway, she calls one day and says, can she come in without him? So, well, yeah, okay. So she comes in and she starts telling me her story and her this and that, and she says she hasn't felt well in 10 years, and she's got all sorts of mental problems, and she can't lose weight and this and that, and we looked at her TSH was 2.6. Well, that's normal, right?
Yeah.
So we sent her for our thing. TPO greater than 2200. Thyroid antiglobulin greater than whatever the max was, 9. I think the TPO was greater than 900 and the TPO was greater than 2200. I said, well, here's your problem here, right? It took us about 4 months. She calls me one day. She says we're going to show you what to do. We took her about 2 months. She says, all of a sudden my brain sort of cleared. And I said, what the hell am I doing? Right? She went back to her husband. She went back to her family. She's a hospital. No, she does nursing home administration. She went and got a job for the first time in 10 years. She bought a new car. And she calls me all the time. She still comes in for Botox 10 years later, right? She doesn't, she says that part of my life never happened. I don't know what happened. I went to doctors for she said she was going to doctors for 10 years and nobody, they all told her she was, basically, mentally ill.
Yeah.
So,
wow.
So I have a friend for life. So
fantastic.
So that's,
cool.
So that's the stuff we can do, and then they turn around and, the endocrinologists turn around and tell you, you don't know anything. You're an idiot. You're this, they call you all sorts of names. You haven't made it in the medical world until you've made it to the Quack Watch list. You ever look at Quack Watch?
Yeah. Yes. I have.
I was on there twice. I don't think I'm on there at the moment, but I've been on there twice. So one was for this. So B12, folic acid. I left that one. I left the folic acid. Ferritin is an iron store, and vitamin D. So you need to get all of those. All right. Especially with the autoimmune patients. The iron stores get depleted with from the thyroid antibodies, and the B12 folic acid also becomes depleted. You end up with stomach acid issues, and it's related to fatigue and mental health issues. Okay. And then vitamin D, our optimal is 50 to 80. If I haven't explained how we get to that, we'll do that as we go along.
Oh yeah.
Okay.
Got that one.
Okay. So this is kind of just a summary of Hashimoto's thyroiditis. This is what we do. Okay. And so here's your endocrinologist and your GP, and this is us. Okay. Remember, we're the quacks, right? So they'll tell you it's a failure to convert T4 to T3. They diagnose it by TSH 0.4 to 4.5. That's pretty much the standard. The hospital lab here has a little different one, but that's about it. There was a little while ago, the endocrinologist says, well, maybe 3.0 is too much. So some of them will say 3.0. Any type of any other issues, any GI issues, anything like that, is you send it to a specialist, right? It's because they're nothing's related. The remedy is levothyroxine, and diet doesn't matter, right? That's pretty much it. Right?
Yes.
If you put in, gluten-free diet for thyroid, the first article that'll come up in most search engines is from the New York Times saying that, gluten-free is overhyped. If you don't have a positive antibody, gliadin antibody on a test, that doesn't count, right? So, but have you worked with some of these people, especially with the autoimmune?
It's been a long time, to be honest.
Yeah. So, if you look for it, you'll find it. Okay. I don't know out here where I am. I don't know if it's because of the, we're kind of downwind from where they used to do nuclear testing in the 50s and 60s, but at least a third, or maybe it's because of what I do, a third of the patients that I see come in with positive autoimmune thyroid antibodies, and they don't know it. And some of them can come in like on the Quest scale, if normal's up to 9, though some of them come in with at 12 or 14, and some of them will come in at 500. So,
Interesting.
yeah.
A third of them.
At least a third of patients that show up for whatever they're coming in for. So we do this. This is part of what we do for everybody. This is just the thyroid portion. Okay, I'll give you the whole list if you don't have it already. I think you probably should already, but okay, but I'll give you the whole list. Okay.
Yes.
Again, these are all the etiologies we look at, and I start at the top and I go down till I find one. There may be more than one, but usually when you hit on one and fix that, a lot of the symptoms will go away.
What heavy metal testing do you do?
Okay, so we look at 5 things: arsenic, lead, cadmium, aluminum, and mercury. Okay, those are the core ones.
Arsenic. Okay.
Lead.
And what tests do you do?
Lately we've been doing mycotox. No, not mycotox. Vibrant wellness.
Vibrant. Okay.
Yeah.
Yes, I've
Vibrant
seen
wellness, and they'll give you a lot more. They'll give you, I think about 12 or 15. I don't remember all the rest of them off the top of my head, but those 5 are the 5 you're looking for.
Gotcha.
Okay. Other things we look at, iodine. And you need to do a 24-hour iodine challenge. Okay, a serum iodine doesn't tell you anything. Okay, when you do other things like zinc, selenium, there should be magnesium in here too. You need to do a red blood cell, zinc, selenium, and magnesium. Yeah, again, the serum tests don't really tell you a whole lot. HPA access, again, we use the reverse T3 as a screen. If you need to go further, then you can do that 24-hour saliva test.
Okay.
Functional GI exam. I like Genova, and we've also been using GI Map. It's a little cheaper. Genova just came out with, they call it Genova Endo, I think, or Endo Plus, and it's got just about every test here, but it's a different module, so you don't have to get them all. You can get pieces of it. Okay, SIBO, and unfortunately, because they're expensive, in my mind, the SIBO should be in with whatever GI evaluation you do. So the GI and whatnot, but it's not. So you have to do it separately. SIBO, we can get this at our hospital lab here. So
you can really?
Yeah, we can. Yeah, in Reno you can. Yeah. So, so ask around. You might be able to find it. They do it the right way. So, they don't do the GI effects test or the GI map test the right way, but they do the SIBO correctly. So you have to drink lactulose, and then they breathe into a bag, and they measure hydrogen and methane over 2 or 3 hours. Okay, micronutrient testing. I really hate that organic oat test. I mean, when somebody brings that, I try not to order it. It's so complicated, and it's so opaque. It takes me 2-3 hours to interpret it because they use ridiculous language. A better one to me is SpectraCell, because it'll say glutathione, it'll say B12, it'll tell you what it is. You don't have to go looking in a dictionary to figure out what the hell they're talking about.
Okay.
The heavy metal testing we talked about. So, and then infectious diseases, the things that you need to look for are hepatitis, Lyme disease, H. pylori, Yersinia, which is stomach flu. It's what is that?
Not pestis, Yersinia.
Yersinia. I forget. It'll come up. Not pestis. No. It's food poisoning.
Okay.
Okay. And the granddaddy of them all is
Epstein-Barr.
Yeah, Epstein-Barr mono. Okay.
So do you look at any of the herpes virus? I've heard about herpes 6 and herpes 7. I'm not an expert. I'm just,
No, I just usually do herpes, usually 2, 1 and 2.
okay.
Yeah.
Okay.
Okay. Okay. C-reactive protein, and then our hormone evaluation. So you want to do all that. Okay. We do use the desiccated thyroids. We do use the combinations. We'll use liothianine only sometimes, T3, and we'll sometimes compound them, if we get off doses. Plant sterolins, I'll explain what those are, and low-dose naltrexone. And if you went through the videos, I got a whole hour just on low-dose naltrexone.
Yes.
And a diet, you really have to emphasize gluten-free. It's really important. And I always tell the patients, this is a Judge Judy deal. It's a yes or a no. Not
Yes.
80%, not 90. You're either doing it or you're not. And if they're not, we try to work with them. I mean, don't berate them about it. But, if they come in, well, I'm not doing well, this and that, what are you eating? And, well, I can't really do this. I said, okay, let's eliminate 2 or 3 things at a time.
Gotcha.
There are certain foods that are called goitrogens. We'll go over those. Okay.
Can you pull it up? I can't see the bottom of the slide. I don't know if it's my settings.
It's got to be you, because I only have a 14-inch screen and I got it here. So I'll send this to you. Don't worry about it.
Okay.
Okay.
Gotcha.
And then food sensitivity. Sometimes we'll do a food sensitivity test. A lot of times, by the time these folks get to us, they already know what foods, and they're going to feel bad the next 3 or 4 days. You have to remind them it's not a food allergy. Food allergy is if you eat peanuts, you're going to stop breathing. It's not that. It's food sensitivity, and it creates leaky gut. And the bad guys are white flour, white sugar, and dairy. Those, that's kind of a short summary.
Gotcha.
Okay.
Okay.
That's it. Sometimes corn, sugar is bad, soy, those kinds of, and wheat. Okay. Next is cortisol, produced in the adrenal glands. This is your fight or flight hormone. Major functions is for circadian rhythm. It stimulates glucose, glycogen turnover. It aids in fat metabolisms, reduces bone formation. It decreases amino acid uptake, sodium and water retention. It's an insulin antagonist, effects on fertility and immune suppression. Okay.
Lord knows what working at night does to this.
It upsets the apple cart, that's for sure. Yeah. So before I go any further, your antidote for your hormone antidote for high cortisol is DHEA. They directly antagonize each other. So if you have a high cortisol, even if the patient, if you measure a DHEA, even if it's adequate, you want to add some. Okay. And you'll be amazed how well that works. Even just 10 milligrams.
Okay. So antidote for high cortisol.
Yeah. So somebody who's stressed out all the time, cortisol levels are high, that reverse T3 is high, DHEA. Okay. That's a reflex. All right. Cortisol, DHEA, right?
Okay.
Here's just a picture of the effects of stress, whether you like this guy or not. Here he is in 2008. He's and now look at, he looks terrible 8 years later. Really, talk about a terrible. I haven't seen a picture of Trump. Must look 40, 50 years older. I don't know how the guy can stand it.
Yeah, that's a good point. It really is.
Yeah, I don't know how the guy's still standing.
Much stress as he's under. You're right.
You people are just not worth it. It's barely. Yeah, I don't know what the hell he needed. I guess it's his personality. What the hell did he need all of this for? He's, he was a billionaire. He did what the hell he wanted and whatnot. And it's got to be an ego thing. I don't know. Anyway.
Yeah.
Anyway, steroidogenic pathway. That was the second lecture. We went through each one of these. But just to point out here that everything comes from cholesterol. The stuff we tell you not to eat. Here's your testosterone. Here's your estradiol. This is your aromatase here, androstenedione. And, you know, what the point here is that the cortisol is actually related to all of these other hormones here. And if we had a 3D, I always say, if you had a 3D, if you had like a pen or something coming out from the cortisol, that's where your thyroid is. So your thyroid and cortisols are interrelated.
Okay.
So you need to keep that in mind. So what happens if you give somebody testosterone? What happens to the rest of this picture? You know, it's going to be thrown off somehow. Might get better, but it's going to be thrown off. So you have to keep that in mind. So stress response syndrome. So cortico-releasing hormone is stimulated with any kind of stress. Remember, good stress, you know, stress can be good or bad. You know that, right? It stimulates the pituitary to release ACTH, which stimulates the adrenal gland to produce cortisol. And there's a negative feedback so that it keeps it under control. Here are the lab values. In the AM, 6.2 to 19.4, which is kind of high. We like everything in the sort of in the center. So, you know, maybe 10 to 13, 10 to 14 is pretty good in the AM. And the PM, a little bit lower. So, you know, we like it maybe about 4 to 8. Okay. If you measure an ACTH, you have to get it between 7 and 10 a.m. That's kind of when it peaks. And again, you want it sort of in the center. So 25 to 30 is pretty good. Okay.
We used to do a test. Do you remember doing that in medical school or residency? I think we'd give a little bit of a
ACTH.
Cortisol stim test.
Right. Yeah. Yeah, you can do that. But again, you could put your reverse T3 in here, and it's going to give you, it's going to tell you what you need to know. Okay.
Similar findings. Okay, cool.
All right. So cortisol dysfunction. Insomnia versus and again, too much insomnia, too little insomnia. Fatigue on awakening. Fatigue, then you get a second wind, and then there's fatigue in the middle of the morning. So 10, 11 o'clock, you need something to keep you going. At 2 o'clock in the afternoon, you need something to keep you going, or you need a nap. By dinner time, you're exhausted. Later at night, they get a second wind, and then they have trouble sleeping, 8, 9, 10 o'clock. And there's usually sugar or salt cravings with it. That's kind of your screening test, and you'll see these patients will start nodding, and you know, I'll say, was that any of that sound familiar? And if you ask those questions, you're going to find that, you know, you're going to find 30%, 40% of your patients that, you know, that's positive. So that's a cortisol dysfunction.
Gotcha.
Okay. So insulin. Insulin, you know, insulin regulates glucose production. It counteracts the action of cortisol and adrenaline, and it converts glucose into triglycerides. So abnormal insulin, you're going to have abnormal triglycerides. Insulin maintains blood sugar levels at a steady rate. It plays a significant role in serotonin production and enhances muscle development. So, you know, when we have good insulin, we have good blood sugar, we have good brains, and we have good muscles. We have bad insulin, we have bad brains, we have bad muscles, and we have high triglycerides. And too much insulin that's diabetes. Not enough insulin is usually hypoglycemic symptoms. All right, so kind of a rule of thumb.
Gotcha.
I mean, there's lots of stuff here, but that's basically it. So, you know, diabetes basically is visual changes, abdominal pain, increased thirst, and that's about it, right? That's kind of it in a nutshell. I mean, you get, you know, you're not going to look at anybody's body in the ER and say, look at them and say, oh, you have high triglycerides. You got to measure that, right?
Right. Yes.
Okay, so we have to pretend you're at the Suba District Hospital in Western Kenya, and you have a Coulter counter there, but it was broke 3 months ago. That's what they told you anyway. It's been broken for 7 years, and nobody's coming to fix it. So, and the closest lab is about maybe 100 kilometers away, and it doesn't really matter because they'll charge them the equivalent of $1. And the patients don't have that dollar anyway, so it doesn't really matter. So you got to be able to figure this stuff out with, you know, in your, on your instincts. So, One thing that helped, I don't know if I ever told you this, I was in Kenya for 9 months. In 2007 at this in the middle of the bush country. So, and by the time the patients they showed up at our door, they'd already been to the grandmothers had given them remedies, and the witch doctor had worked on them. They were the Maasai warriors. That's terrible.
Yes.
So by the time they came to us, God knows what they had taken. So, and we had nothing. We had an X-ray machine, but it was cobalt and it was unshielded. So while I was there, I wouldn't let them turn it on. And then they had a Coulter counter, but when I left after 9 months, the next guy who came in, I heard him say, he says, "Yeah, the machine's broken. The technician will be around here in 3 months." And 9 months before, they told me the same thing. So I think that was just a running joke. We learned pulse and tongue diagnosis, and to look at colors, like especially under the eye. It's a Chinese sort of pulse and tongue diagnosis, and so I used a lot of that for how I did things. And it was as good as any.
For diagnosing insulin dysfunction?
Well, diagnosing anything. I mean, like I said, we didn't have anything to diagnose with. The two things they did have there, they had a really good internet connection. And remember, 2007, it was still, fairly new. And they had, if there was an AIDS drug made by an American company on Monday, by Wednesday, they had it there. Right? They didn't have penicillin. They didn't have potassium. I remember that.
Wow.
They didn't have, they didn't have potassium. They didn't have penicillin. They didn't have beta blockers at all. They didn't have digitalis. So I'll tell you a story about guy came in heart failure, which was pretty unusual. So the life expectancy for a male in Kenya at that time was 46 years old, and the female was 52.
Wow.
So a guy came in. He was there when I got there. He was in heart failure. He was 50 years old. He had congestive heart failure. So the intern tells me, he says, "Well, we give him the diuretic for 3 days, and then he gets better. And then when we stop it, it comes back." I said, "Well, what are you stopping it for?" He goes, he says, "Well, they get neuropathy." I said, "Well, need to give them potassium." He goes, "Well, we don't have any."
Oh,
okay. Okay. All right. I'm not in Wilkes-Barre, Pennsylvania anymore.
no, you're not.
Yeah. And one guy I felt really bad for. I think I was there a day, and the guy had something you won't see here. He had he either had a spinal cord tumor, that a rapidly progressing spinal cord tumor. They told him that he had TB meningitis. If we were in the U.S., he'd been in the operating room within an hour. But there it was like, nothing we could do for him.
Ah, gosh.
3 minor hormones. I call them minor because, so DHEA, Pregnenolone, and Prolactin. And this is my AI form of it. So you can see they don't spell words right, but I thought it looked kind of neat, the book.
Yeah, cool.
Got my name spelled right anyway. All right. So DHEA, is in that cascade there. Let's go back just. I want to do that. So you can hear the cat. So here's your DHEA right here.
Gotcha.
Okay, right here, and it converts to androstenedione and testosterone. So DHEA, you can think of it as sort of as a mini testosterone. It has all the characteristics of testosterone, just sort of on a minor scale.
Okay.
Okay.
When I'm correcting it, what do I want my levels to be?
So DHEA, 200 to 250. So when I first started, I remember, I told you how I wandered into Neil Rosier's class, by accident.
Yes.
Yeah, I think for guys, he wanted it at 600, and for women, he wanted it at 300 to 350. And that was in the early 2000s. So I don't know if he's changed it at all. He makes me a little crazy when I listen to him. He's kind of sarcastic, So.
Well, oh yeah, it very much is, and that's what drove me away from treating thyroids, because I was going, man, I just don't feel comfortable going this high and
Yeah.
not having any stopping points. That was
Yeah.
the biggest thing.
Yeah. Did he talk about estrogen too, or he just lets the estrogen ride too?
I can't remember,
Was he
but
doing that? No. Okay.
oh yeah, and he was going testosterone levels that were for weight loss that were just exorbitant.
Yeah. I know. Okay. So again, so DHEA, just think of it as a mini testosterone.
Gotcha.
High DHEA levels are neuroprotective. Low DHEA levels are due to stress and aging. Okay. So when DHEA levels are low, you probably have high cortisol levels. Okay.
Okay.
So that there's a you can find a DHEA cortisol ratio. Sometimes some literature will be cortisol cortisol to DHEA ratio. It'll be the opposite. Okay. So when you see the numbers, you have to remember which one comes first. Okay. Again, too much DHEA, the same as testosterone, oily hair,
Gotcha.
oily skin, acne, bossiness, anger, road rage, excess facial hair, not enough, basically low testosterone. Noise intolerance, that's usually a DHEA thing. Okay. So visual intolerance, so bright lights and things like that, that's a pregnenolone deficiency, and or a cat deficiency. So,
Yeah.
okay, pregnenolone, that's your other. So pregnenolone is your hormone of memory. Okay, that's it. That's all you need to know. Repairs damage. It stimulates GABA production, increases stress resistance, acts as an anti-inflammatory. But basically, pregnenolone is your hormone of memory. Okay.
Okay.
The only way you really get too much pregnenolone is if we're treating somebody and
Yeah.
and we go overboard. Our sweet spot here is about 90 to 110. Okay. And
Okay.
then sometimes it'll show up, they were at 27 and now there's 250. So I usually just slow it down after that. And then prolactin. So high prolactin, is usually a pituitary adenoma.
Yes.
They get, across the board, the pituitary hormones are abnormal. And but low prolactin, which is less than 6, is usually a sign of treatment-resistant either anxiety. They have chronic anxiety and depression. They're taking 2 pills, 3 pills, 6 pills. Then they have to take 3 pills for the side effects of the 6 pills. The 6 antidepressants and anti-anxiety agents, and they've been to 3 psychiatrists and 2 psychologists and the iridologist, and they went to India to the ashram, and they're always looking for the cure, and it doesn't come. A lot of times these folks have had head injuries, and it doesn't have to be a major one where they were unconscious for 6 months. It could be that they it was just a mild traumatic brain injury. But one of the hallmarks is low prolactin, less than 6. So we do prolactins on everybody. And usually you need to do atypical antidepressants, anti-anxiety agents for these folks. The usual stuff, the SSRIs and those kinds of things usually don't work. And they'll tell you that because by the time they get to us, they've been on this stuff. So they'll tell you that. Okay. You're yawning, and it's 7:30. It's been about an hour. So
Yes.
why don't we cut it off here? And next time we'll talk about labs.
Okay.
We'll tell you how.
What do you do? What do you do for the low prolactin levels?
Usually it's you want to sort of bolster the neurotransmitters. So again, if you're measuring neurotransmitters, I think Cyrex does it.
Yeah.
You want to look at that first. Sort of a universal thing. We give them GABA. Okay, we start at 100 milligrams and go up to 400. Usually once a week, we'll increase it by 1. I like Thorns. We're not CME, so I can give you my thing. So I like Thorns.
Yeah.
It's called PharmaGABA. It's 100 milligrams. We go up by 4. We tell them if they're too sleepy the next day to cut it back by 1. Usually 1 or 2 is enough. So we'll talk about the neurosteroids and the brain pathway, and it'll make a lot more sense.
Okay.
Okay. But the just real quick, the benzos, the Valiums and Xanaxes and all
Yes.
of those, stimulate allopregnenolone receptors in the brain to produce GABA. That's how they work.
Fascinating. Okay.
Okay. But the benzos are addicting. There's drug interactions. And they're overall, it's not great to be stuck on those. Okay. We can, off our shelf, we can give them the end product. We can give them the GABA and bypass the whole, the whole benzo mess. And it's just a little bit more. I think you can get Valium for $10 for 30 of them, and the GABA is not that expensive. So
Fantastic.
yeah, so we can bypass. Like I said, we can bypass the whole mess. Then they go to the hospital to have whatever done. They get their hip replaced, and the surgeon tells them, "Get off all that junk. It doesn't do anything."
Excellent. Thank you, sir.
Okay.
Great.
So let's see. So I'm at AMMG this week. I'll
Yep.
let you know how that goes. We'll pick it up here. If you have any questions, I'll be filling in that
Dosing.
as I go along. I'll try and fill it in for just the treatment protocol, so you'll have just that. Okay.
All right. Good.
Okay.
Very helpful.
So each one I send you will have whatever we had, what you have now, but I'll be an add-in. Okay.
Excellent. All right.
All right.
Yeah, and I'll coordinate. I think we're back on schedule next week. So
okay.
Okay.
Yep. Thank you. And
Thank you.
how do I get out of it? I never know how to get out of this thing.
Yeah.
Let's stop the